you think that pulpotomy is an obsolete treatment or not?
I don't know if we can call obsolete treatment, but certainly I don't see myself in that situation to do a pulpotomy very often in the last 15 years, because the selective removal of carious tissue has been in my practice from almost 20 years now. And if one of the things that we can say about pulpotomy is that has the same indication of selective removal of carious tissue. Yeah, I think South America is leading in that area of selective carious removal. We have a strong evidence now to support that clinical approach.
I started teaching pulp therapy last century, and I mean it, in the 20th century and the 70s. And at that time, the practice was that you took a radiograph and you see the caries approaching the pulp, and it would be indicated for pulpotomy. From that time, we made a long way. And definitely, I believe that the truth is with the South Americans. And selective caries removal to soft tissue is the answer. But the most important point when I teach into our graduate students, the main point is having a good diagnosis of the situation of the pulp, because, well, I don't mean you're really giving a big lecture on the thing, but you really have to remember that we have pulp reversible inflammation and irreversible inflammation. So we cannot do histology to see, or histochemistry to see, that you're really dealing with a reversible or irreversible. But with all the history that you take, and then the clinical examination and the radiographic examination, you really can come to almost a good situation or diagnosis of the situation of the pulp, if the inflammation would be reversible or not. And if the inflammation that you imagine is reversible, indirect pulp treatment or selective caries removal will be definitely the treatment of choice.
In Mexico, we still do pulpotomies in case that there's no chance to avoid the pulp exposure and we decide that it's a vital pulp. We still are doing a pulpotomy.
There's a decision tree that you would employ while doing pediatric dentistry, pediatric endodontics on a primary tooth, right? It's different than a permanent tooth, and even a young permanent tooth with open apices and a young permanent tooth with closed apices. That's not necessarily an adult tooth. So for the primary tooth, I would definitely agree with Anna that pulpotomy has its special, unique place in pediatric endodontics. But because of the rise of selective caries removal, there is definitely more space for vital pulp therapies employing selective removal of, because in my point of view, it's just maintaining a little bit more pulp space, which is the coronal pulp space. But at the end of the day, you're saving the radicular pulp, so there's almost no difference for me, provided that we employ the proper technique, all right? But there is, I believe, pulpotomy is a rising star for anterior primary teeth as well. It used to be a taboo, all right?
Yes, we'll talk
but
about
now
later.
if you look at the new treatment, if you look at the new trauma guidelines, you will see that for primary teeth, pulpotomy has been cited for the first time in the literature as an option. I'm not talking about also trauma is another reason we might have exposed pulp. So for anterior teeth, I think it's never going to be obsolete. Just on the contrary, with the rise of bioceramics and less leaking coronal restorations, it's just on the rise. So it may not be our plan A for posterior teeth anymore, but it's definitely going to be plan A for anterior teeth in the near future. So that's what I think.
I just want to say one thing that as per the recent AAPD oral health policies and recommendations, pulpotomy is the most frequently used vital pulp therapy. So I think it cannot be obsolete, or it cannot be taken away from the clinical practice. As well as if you see the current literature and so many, what do you call, the randomized controlled trials which are published, especially on pulpotomy. If you see any of the best possible pediatric dentistry journals, it's only endodontics is only pulpotomy, and there is probably a lesser extent indirect pulp treatment. It's mostly pulpotomy. And we do carry out pulpotomies quite regularly, and it is one of the most frequently carried out procedure as far as India is concerned.
Mm-hmm.
Okay, so in Saudi, we're kind of between Latin America and India. We do a lot of pulpotomies for sure, but not as frequent as I did when I was an undergrad myself. We teach our students to be more conservative now. With all the new materials and all the new evidence that you can do selective caries removal, we definitely do that. We don't do as many pulpectomies as probably in Latin America. We don't do them for D's whatsoever. We only do them for the second molars if we need to do them. And as Dr. Fuks was saying, there is a place for pulpotomy. It cannot, or at least in our population, we cannot say pulpotomy is obsolete. We try not to do it if we can, but we still do quite a lot of that, especially with our population. The other thing that we are now exploring with more confidence is the direct pulp capping. Before, if we got an exposure, we automatically went to with pulpotomy. Now we're trying to do more pulp capping, especially after I think it was 2 years ago, the guidelines with the reference manual of the American Academy of Pediatric Dentistry was this comprehensive review. Although the evidence was low, it did show that it was more promising than it used to when I was an undergrad. It was a complete no, and again, because probably calcium hydroxide and the internal resorption issue. Now we are doing more direct pulp capping with confidence, especially in anterior teeth with trauma, as Dr. Zafer was saying. But we are still not completely avoiding pulpotomies. We still do them, and we kind of still do them a lot.
We reduce the amount of frequency that we have been using for pulpotomies. Pulpectomies has decreased even more. But here in the US, we are highly influenced by the insurance companies. And why is that? I mean, it's as simple as that it takes you more time in the operatory chair to do a pulpectomy rather than to do an extraction and space maintainer. But these are the reasons, but that doesn't mean that the guidelines are not recommending pulpectomy, that the guidelines are not recommending to change pulpotomy. Actually, they are telling you, and the systematic review that Deema was mentioning, it was published in 2017, and we still use that one. And and being used in 2017, and they haven't changed it or modified. It means
we're not doing the for non-vital teeth now.
Non-vital teeth, exactly. So in here is like they are telling you with the same amount or like result, positive result, that they cannot even recommend only one. It's at the same level: direct pulp capping, indirect pulp treatment, and pulpotomy. And they don't have recommendation on materials. We will talk about that later. But in the meantime, I just want to agree with the concept mentioned, but very important to mention or to repeat that we are highly influenced by the insurance company. But we are still teaching in undergraduate level and graduate level all these things.
almost everything has been said. I just want to say that it is another option. It is not an obsolete treatment option, but we should consider it as something between black and white. Just imagine a baby, a non-cooperative kid, very small kid, and you are trying to avoid a pulpal exposure. And in the last time you do a pulpal exposure, you have to do a pulpectomy. This is something, it is a very good option with new materials, with new bioactive materials to solve the problem between black and white. White is maybe not non-pulpal exposure, and black is pulpectomy. It is something that you can do fast and predictable and with very high success. So I think it's not an obsolete option.
One thing I would like to mention, being a pediatric dentist, we should be as conservative as possible. Second thing, pulpotomy is always a clinical decision along with your support of your clinical diagnosis as well as radiographic diagnosis. And the third most important thing right now, when we are discussing where to stop exactly, whether to stop at indirect pulp therapy, direct pulp therapy, definitely pulpotomy is well established. And there is a huge amount of literature supporting pulpotomy. So we cannot consider it as an obsolete. Regarding India, we are performing it very regularly. The most important thing which I would like to mention over here, that is your case selection for the pulpotomy. If that goes wrong, then the treatment goes wrong. So that is the only thing that I would like to.
I'm happy to see that diagnosis is the main thing. We still consider pulpotomy as a good treatment of choice. Great.